Okay, let's get to the heart of the matter. We want to hear from patients. We want to hear from primary care clinicians. I'm first going to welcome Lisa Gables, who's going to moderate this session. Lisa's an associate executive with extensive experience in healthcare and aging services. She was named Chief Executive Officer of the American Academy of Physician Associates in September 2020. She was the interim CEO and then became CEO. She's on our finance committee. She's a wonderful colleague and friend. Lisa, please come to the stage. And also all of your panelists, who Lisa will introduce, and then we'll see a video and have a panel conversation.
Thanks so much again, and good afternoon, everybody. Excited to be here. So I wanted to just start off by saying we have a huge panel here as far as their expertise in primary care. We're starting off to welcome Dr. Scott Conard. Thank you so much for being here. Dr. Conard is the founder and partner at Converging Health. Today, we also have Sarah Coombs, who is the Director for Health System Transformation at the National Partnership for Women and Families. And we are so pleased to have Lauren Page here, who is a clinical supervisor at Menocal Family Medicine and is here representing patients as well. So more about these folks in our agenda if you want to read more. We are so delighted to have all of you here today to talk with us about the important issues facing primary care. This diverse panel is here with us today to provide reactions and their thoughts and commentary on the stories we're about to see in this video.
I am from India. I'm 63 years old, and I came to this country when I was 29. I was a college professor who decided to become a primary school teacher, and I was there for 20 years, loving every moment of it.
Here's my story. I was so busy being a foster parent and a wife, and had a sick husband, and just taking care of everybody, just pouring into everybody and not pouring into myself.
I had the same doctor my whole entire childhood, and then moving into college, I didn't know what to expect, but my student health center was great. And I was able to have kind of the same 2 nurse practitioners for my entire 3.5-ish years. I could message, I could call, and I really had that relationship. Then I graduated, and I was kind of set out to find my own primary care doctor for the first time in my life.
I have had issues with health since I was a child. I was 16 with high blood pressure. I had diabetes. I was trying to take care of it, but it wasn't always taken care of. So it allowed for more things to happen to me, like dialysis.
I raised my children on my own, and knowing that I've overcome what I've overcome, I want to be able to empower my patients the same way. I have a passion. I'm very empathetic when it comes to their needs, and it's just rewarding in every way. Just being able to walk with patients on the walks of their lives.
Somewhere along the way, I realized that I wanted to be taking care of people long term. So just being able to take care of someone for a day or a week or a month was great and really rewarding, but not as fulfilling as being able to watch somebody along their health journey for years. And so that's how I ended up with primary care.
I started my relationship with my primary care physician in 1993, and I had her as my primary care physician for 30 years till she retired. She was not only my primary care physician, but she was also the physician for my two sons. But even though they went to college and everything, they would come back. Well, it was like visiting family. But then slowly, things started changing. Every time I went in, I would see a different nurse. They would be like, 1, 2, 3, 4, we're done, we're gone. And I could see it was taking a toll on my physician, and the connection was not there anymore.
It was, a new insurance, and that dance of no one could see me 2 weeks, 3 weeks, 4 weeks out. And eventually I did find a primary care, but if I was sick and I needed to someone, in a day or 2 days, I had strep, or, I work with kids, so I get sick a lot. And I just wasn't able to get in. And I was finding that that was the case with a lot of the offices that were kind of listed in my network. And so then, you just end up at the urgent care. I know all the good ones. I know the fast ones. I know the ones that are open on Sundays. And they were the ones that were able to see me, and my primary care was not.
Finding a primary care doctor was actually kind of difficult for me. And it was me, my auntie, and my sister who are my advocates. We were actually out there like trying to reach out to find one. There were so many of them that said that we're not taking any new people. We looked and we looked and we looked, and the one I have now feels like he actually cares, because we actually had a conversation where he actually got to know what I like and what is better for me.
No matter who you're meeting with, how straightforward or how complex a person's medical problems are, it takes time to create a trusting relationship. And without a trusting relationship, there's a lot less to gain, I think, from primary care.
I ended up having another stroke, and it was a big stroke. And I was paralyzed on the left side. And I'm still having that problem with my face right now on the left side. But I'm grateful because I got a primary care person, and she really helped so much. It was just so great to have her. And she even asked me if she could be my primary care person. Can she follow me? And I didn't know what that was and what she would have meant at first. And then she explained it. And so I agreed. And I'm telling you, that was a godsend. And I am so glad that I was able to get her. And she found other things that was going on with me. I didn't know I had kidney problems. I didn't know I had bladder problems. She helped with all of that. Now, had I had her at the beginning, I probably wouldn't have had that stroke. I probably would have been able to take care of myself knowing that I had high blood pressure. I didn't know that. I didn't know I had high cholesterol. I didn't even know that I had diabetes. And she helped me with all of that and walked me through so much. And she was so caring.
Community health workers are vital with patients' care because, for one, we identify as members of the community, which helps to build a trusting rapport to be able to work on those long-term chronic health goals. For example, you may have a patient who may be afraid to express a need to their provider. So one of the things that they can do is reach out to me, or I'll reach out to them and support them at their appointments to help them to be able to ask questions and to be able to understand things relating to their health to try to become healthier.
We don't need paperwork, we need people. And primary care is where the people are. And definitely used to be, please do not let the division of medicine disappear.
The direction our healthcare delivery system is moving is unsustainable. And in order to change that, we're going to need to continue the work that we're all doing at a national level, state level, local level, but we're also going to need drastic change. We know that the majority of heart disease and type 2 diabetes is preventable. And I think that work happens in the community. It happens at home, it happens in school, it happens in our kitchens, it happens maybe in the church, but it essentially happens in our community. And how can we as healthcare practitioners enable that? I think that work needs to happen in primary care.
I'm not just a number to him, but I am a person and a patient to him. And he asks me questions. He asks me how I'm doing. He asks me how the things that he's set up for me are doing. He's just to make sure that everything is going how it's supposed to be going. I'm grateful for him and looking out for me as I keep continuing to go through this thing, because it's not easy for me, but I'm doing the best that I can, and he's helping me do the best that I can.
Wow, powerful stories, huh? To ground us in our work today, as Mark said. So let's just get right to this. I'd like to start with your feedback, and Scott, I'd like to start with you. Based on your work for many years, you believe in health transformation and redesign. Given the challenges that you just heard from the patients today, what do you think are the 3 biggest elements our healthcare delivery system needs to redesign to ensure that primary care doesn't disappear?
Thank you so much, first of all, for letting me be here. So the 3 things are, number 1, we need to pay for whatever we want the outcome to be. Right now, you get what you pay for. We've got a perfect system to generate higher volume and higher cost. And I would like to advocate that we separate primary care in a reimbursement model from specialty institutional care. We're different. We think differently. We take care of whole people. We don't take care of problems, diseases, and perform a procedure. So I think we need to get prepaid advanced primary care, number 1. Number 2 is we need to reimagine our roles in the people's lives that we serve. And the joke called primary care today, when you talk about the urgent care center and running people through at 7 minutes a visit, it's a travesty. That's not what we do. And my dad is a family doctor. I'm a family doctor. My daughter's a family doctor. And what we do is we love up on people, and we care about whole people. And Wayne Jonas is here. He wrote the book, How Healing Works, and I think we need to reinvent primary care around the hope note, not the soap note, and about relationship, not transaction. So we've got to, and this starts with the teams of primary care clinicians that are in the offices that are seeing patients. That's where we've got to start. Because once they understand their beauty and their power and what they can do, what they will do with those human beings will absolutely bless them and keep strokes from happening and keep terrible things from happening. And so number 3, data. The difference between 1995, where we got Travelers and Prudential and all those, and United used to call, I guess Prudential was what United Healthcare was way back then, and Aetna was shoving patients at us at $12 per member per month. We had no data, we had no information, we didn't know what we were doing, and it was a disaster. Today, data informed, we can take that 26-hour day that we're supposed to work to see 20 people and divide it by 4. We can have the navigators, outreach people take 6 hours. We can have our medical assistants, nurses take 6 hours, and we can have the back-end community health workers / navigational support take 6 hours, and we get to work 6 hours. And that only happens with effective data. So to summarize, and I'm trying to be fast, payment reform, so you pay for what you want, which is decreased health risk. I dedicate my life today. We have the whole person risk score. We put that at the fingertips of primary care doctors, and they can see that go down. It's a leading indicator for utilization and costs. Those are lagging indicators. You don't manage utilization and costs, you manage health risk. So we need to pay for decreased health risk. And I know it's not easy, but it's possible. Number 2 is we reimagine. We have hope, not soap. We're not secretaries for the insurance companies chasing gaps in care and HCC codes. We care and we love up on our patients. And 3 is we've got to give. The American Academy of Family Physicians, who's here today, has a white paper that they're producing on data and how to use data in primary care to transform care. And that's the foundation of all of it. So that's my answer.
Great. Thank you, Scott. Sarah, I'm going to turn to you because you have a lot of experience also in working toward healthcare transformation, specifically related to healthcare policy. So the same question, what do you think are the 3 biggest policy elements that we need to change?
Can you all hear me?
All right, well, thank you for having me, and thank you for kicking off this panel with that video. I think it's just so important to ground these conversations and centering lived experiences and patients' voices. So I'm sure a lot of what we heard in the video resonated with many of you, as it did for me. I really related to Valerie in some ways. I think, I bet if I polled everyone in this, well, the women in this room, they would agree with me that when it comes to healthcare, women are often the chief medical officers of their families, right? And they are disproportionately the unpaid family caregivers. And so what that looks like is they're trying to juggle, you know, the appointments for their children, their spouses, their parents, their neighbors, they're members of the church community, and they often neglect themselves, right? And I think what we heard from Valerie was that she was pouring so much into others and forgot to pour into herself, and ultimately she neglected her healthcare needs. And so that's so true for many of us, but I also come from a privileged position. You know, I think about the person with limited English proficiency, or the person who works multiple jobs, has, you know, no paid sick days, no insurance coverage, little pay, you know, or has limited child care, or lives in a community that's systemically underserved and has limited access to nutrition, healthy built environment, you name it, all these structural barriers, which, you know, gives us no surprise that that people are having difficulty being healthy and staying healthy. And so we need to transform our healthcare system, and that starts with changing the way that we pay for primary care, as Scott mentioned, and as Mark mentioned earlier. We need to change the financing of primary care, because a lot of you all in this room are doing way too much for too little. And so if we invest more in primary care, you know, I think primary care providers will have more time to spend with their patients, to get to know them better, to get the kind of care that Brian was receiving, right? Being treated like a whole person, and, you know, and able to have care coordination with care teams that can follow them, and have their, you know, social needs, behavioral health needs, specialty care needs all integrated. That all requires investing more in primary care, and it also requires just changing the payment mechanism. I think there's so much promise with value-based payment and prospective population-based payments, but we also need to make sure we're paying for equity. We also need, we need to make sure that we are, you know, having payment adjustments that can support safety net and small and community-based providers, and provide upfront infrastructure investments that can enable them to participate in these kinds of models, that can help increase these high quality primary care models in underserved communities, right? And we also need to ensure that we listen to the people and communities, because they are the experts. They are the experts on what they need. We need to ensure that we center their expertise and integrate that expertise into everything that we do, into all the policy making and program development, implementation and evaluation. And I think that we also need to support practices and providers with the tools, the resources, the guidance, and knowing how to meaningfully engage patients and consumers. So that was a lot, I'm sorry.
That's okay. Way more than 3, but that's all right. So Lauren, you have worked as a clinical supervisor in a primary care clinic, and you also have a chronic condition. You see these issues from both angles. One of your professional responsibilities is to deal with paperwork. We all love that. We heard in the video, patients are struggling to deal with this problem, insurance issues, all sorts of problems that force them to seek treatment in other places than primary care, like the emergency department. Do you have any suggestions on how regulators can deal with this barrier to helping people just get the care that they need?
Yes, paperwork isn't fun for either side of the fence. I do think that a lot of times patients are thrown a packet of paperwork and like, okay, bye. And they have to go home and they just kind of let it sit there. They don't process it. Nobody goes through it with them. We always try to make sure that as you're checking out, that literally every page that we're giving you, that you understand what's going on. And if you don't, I pull you aside, I'll schedule it for you, I'll get you here, we'll set up a ride. We try to make it literally so all you have to do is show up. I don't think we'll ever get rid of paperwork per se. It's one of those things that I think it'll just go on forever. But I think if patients have a better understanding of what the paperwork is and for it to not be intimidating, it's not as such of a bad thing. They understand what it is. This paper is a referral. This is this. This is this. And it makes the process better for them.
Very good, thank you. I wish paperwork would go away. Don't we all? Sorry. So Sarah, one more question for you. We heard a person in the video actually say that we need more healthcare at the community level, and you just talked about that too. What do you think is needed to bring more clinicians back into primary care?
That's a great question. So I really love what Dr. Gupta in the video said. She said that primary care happens in the community. And at the National Partnership, when we think about community, we think about partnership. We think about having a village, a team. And so I think about team-based care and how team-based care can really not only improve patient experience, but it can also mitigate the burnout that so many physicians are experiencing. So team-based care is so foundational. It allows team members to practice at the top of their license. It allows patients to experience care that is coordinated and integrated with community health workers like Tawanda in the video, with peer recovery support specialists and social workers, and all the really important non-clinical and clinical support staff that can support patients and caregivers, and also the primary care physician quarterbacks, right? That need that support. And so going back to the payment problem is that our current payment system doesn't really enable interdisciplinary care teams to deliver those flexible services that can be tailored to patients and community needs. And so, I think it's just so important that we, have a comprehensive primary healthcare system that is appropriately financed and incentivized to ensure that we have interdisciplinary care teams that can, support that high quality, equitable care that we need and that patients need.
I love that answer. The patient is always in the middle when you talk, is the forefront of this, and the patient's in the middle around the care team. So good answer. So Lauren, as a patient, actually, what advice do you have for clinicians in primary care who do seem to have so little time, but many want to build that trusting relationship with their patients? What would you tell them?
I would say to follow through and to have a good team. A lot of times you sit in front of a doctor and they tell you this and they tell you that, and they're gonna do this and they're gonna do that, and then you leave and the ball drops. I've had diabetes since I was 8, so I've kind of seen and went through the motions. I've watched medicine kind of grow as a whole, but for me, it's always the follow through, to basically just do what you say. And even if it's not the physician directly, but to have your medical assistant follow through, or the receptionist call me and say, hey, they didn't forget, but just to know that you're not forgotten. I understand that, a lot goes on throughout a day from, again, both sides of the fence, but to me, it's major if you recognize and remember, like the video said, I am a person, and that my health matters just as much as the next person, regardless of my insurance, my condition, that basically you're gonna do what you say.
That's very good advice. I think the follow through is very important. I don't know any of you in the room have experienced this, being at your primary care practitioner and you get a call, the next day, how's it going? It's very nice. So good advice. So Scott, last question. As a physician, you have learned the value of being proactive with your patients to help lower the risk of life-threatening or chronic conditions. You talked about that earlier. What needs to happen to shift primary care from a place where someone goes just because they feel sick or have a broken arm to some place that's more wellness centered or preventive care based? What do you think?
Well, I think that, so the journey of my career and the journey of UNS Healthcare is the same. And that is that when I was 36 years old, I was practicing medicine. I had 3 patients die over the course of a summer. Now, the problem was they were all in their 40s. One of them was my best friend, and 2 of the 3 were women. And at that moment, I woke up and I realized that I wasn't effective as a clinician. And so I went back to their charts and I looked it up, and the risk factors were there. So the first thing is that, and I say this to my daughter all the time, sweetheart, I feel fine and I am healthy are the same about 60% of the time. And I want everybody to feel fine, but the human body's miraculous, and there'll be a moment when, if I were to have a heart attack in 15 seconds, you said, Dad, how do you feel? I'd say, I feel fine, and 15 seconds later, I have a 50% chance of being dead. So it's a delusion to think in primary care that I feel fine and I'm healthy are the same thing. So we have to shift the mindset to that health risk model that we were talking about, which is how do you figure out if I feel fine as I am healthy or I feel fine as I'm 15 seconds away from a major event. So that's number one. Number two is 90%, they say, the smarter people than me in the world, 90% of healthcare costs are related to chronic and mental health conditions, or in people with chronic and mental health conditions. The wonderful news there is that they follow a pattern. They go from stage 0, which is no disease, to stage 1, where you've got pre-disease. Stage 2, we've got disease without complications. And stage 3, where you've got disease with complications. And you can identify every single human being as being in a continuum on the key things, whether that's cardiometabolic, which is diabetes and vascular disease, or musculoskeletal, or women's health issues. So you can figure that out. So now as a clinician, armed with that information, I know how to move people back to no disease or pre-disease instead of allowing them to charge forward into disease. So we're back to data, we're back to whole person health, because the reason that a person doesn't lose weight, or the reason, and I was obese when I woke up and realized, oh my God, I feel fine, but I am not healthy, at 36, and now I'm 50 pounds less, and today, 40 years later, the thing that we have to have the information, we have to have the right mindset, and then we have to shift to that whole person perspective. Because the reason that I was obese wasn't that I didn't necessarily know what to do, it was that I was working too hard. The tyranny of the urgent was ruling my life. I was eating fast food, and I didn't understand what it was doing to my body. So it's a health literacy engagement, which is not a transaction, it's a relationship, which is the foundation of primary care and what we need to do. We need to get away from this, here, send in your CPT and ICD-10 codes and we'll send you $100 mentality to I take care of human beings and a whole person, and I need to know their society, their social whole, structure and their emotional structure as well as their physical structure. And I need to relate to them at all of those levels, simulcast at all of those levels to be effective. So being a great clinician requires the system to nurture and pay for that, and it requires the system to provide the information to do that.
What you just described is kind of eye-opening when you address a patient with, how do you feel today? Versus, let's talk about the stages of disease. It's a different mindset.
It's a different mindset. I had to write a book called The 7 Numbers That'll Save Your Life, which, by the way, anybody who wants to give it away to you free, my email is scott@scottconard.com. And I give it to my patients because I'll do their annual exam, their physical blood work, and then they'll have a problem. Well, I know I need 30 minutes to educate them, and there's no way I can stop my day for 30 minutes. So what happens is I give them the book. I say, would you read chapter 1, 2, and 4, which is on diabetes or hypertension or whatever, and then I'll see you back in 2 weeks. And so we raise their health literacy so you can actually communicate with them. It'd be much better if I was cool like y'all and could do like videos and, TikToks and all that stuff. My daughter has these channels where she like communicates with her patients, but old white men, we haven't figured that out yet. So.
All right, we just have a couple more minutes left. I just want to ask each of you, this is a surprise question, if you could give this audience a call to action, what would it be? Just quick, off the top of your head.
You go first.
Is this on? Okay, yeah. I just want to go back to the very last point that I said. Listen to your patients, engage with your patients, engage with the community. Do it in a meaningful way. I think without them, nothing that we're going to do is going to be effective or successful. And I think what's been missing in this last decade or so of like the value-based care movement is the patient voice and the community voice.
Amen.
Good answer.
I would go back to what I said with following through. The difference it makes is huge, and to know, like I said, that you're not just a number, not just a patient, that they know who you are, they relate to you, and that they actually care will go a very long way.
And I'll go back, I was talking about being an old white guy, to the things that have mattered most in my life is not the huge, glowing victories, it's relationships. And we have each other. I feel like I'm with my tribe here. I want to get to know every person in the room. I'd love to be able to find out your story and why you're here and what this means to you, and really be able to lift you up and encourage you, because we need each other. And my call to action is not really a call to action. It's a great big hug, virtual hug that says you matter, you make a difference, we need you. Do the little things, hit the little thumbs up when you see a post that you like by somebody that you believe in, and stay involved with the PCC. PCC is, with Ann and the other leaders, Dominique and so forth, are bringing together influential policy influencing people. And so let's support the PCC. And she didn't ask me to say this, by the way. And support what Ann does so we can get the policies done, change the compensation, reward primary care for really making a difference. I believe we're destroying the middle class in the United States of America with the current healthcare system. And it's got to stop. And I hope you get up as fired up and angry about that. My whole family's butchers, teachers, preachers, and we have 3 doctors. It's kind of bizarre. But my middle class family is not going on vacation, and they're not able to retire because of the garbage that they've experienced in healthcare, and we need to stop that. So count me in. I'm there with you every step of the way, and if I can ever do anything, let me know. But don't underestimate the importance of the little things in staying engaged and staying involved.
That's great advice from our panel today, and a call to action for each of us to stay engaged, to remember to put the patient first, and to always think about hope. I like that message, that there is hope on the horizon for us. So thank you all today. Thank you to our panel.